Hello, everybody. I hope you can hear me. If not, please write into the chat and I can see that. My name is Markus Möller from Aachen, and I have the pleasure to introduce Paola Romagnani, who will give the talk today. Paola is well known in the scientific world of nephrology. I will briefly read you her CV so that you can get to know her. So she graduated and obtained her PhD in endocrinology and her residency in nephrology at the University of Florence, where she's still today. Today, she is a full professor and a chair of nephrology at the University of Florence, and she's heading the Nephrology and Dialysis Unit at the University Children's Hospital. So she's a pediatric nephrologist. Paola has published many papers, 247, and she has an H index of 87, which demonstrates her scientific power. Her studies have received over 26,000 citations. She has been in the editorial board of the Journal of the American Society of Nephrology and of Kidney International. She has given multiple lectures, 400, and she has been awarded 3 ERC grants by the EU. She has been awarded the Höchst Marion Rousseau Young Investigator Award in 1999, and she has been in the Scientific Advisory Board of the ERA EDTA, and she won from the ERA EDTA in 2020 the award for outstanding basic science contributions to nephrology. So today she will talk about immune glomerulopathies, and we are very much looking forward to your talk. If you have questions, please submit them to the chat. I will see them and take a note and later pose your question to Paola after the talk. Thank you.
And thank you, Markus, for the kind invitation, for the kind introduction. So the topic of the webinar today is about glomerulonephritis. As the term says, these are inflammatory diseases of the glomerulus. And why? Because we recently, with a group of colleagues, tried to reclassify these diseases based on a pathogenesis and treatment-oriented approach. And why it came into our mind to do this, why we felt this need? Well, of course, different person may have different motivation. Here, permit me a personal note. When I was a student, I spent the day before my nephrology exam at the medical school all the day to repeat glomerulonephritis. And this because I couldn't understand and then I couldn't remind them. And that's why I needed to repeat them many times. And like it frequently happens in these cases, the following day, the professor at the exam exactly asked me this question. And I could respond to the question only because the day before I had learned them as if it would have been a poem. But of course, this is not how we should learn diseases. And then later, I had the same experience as a teacher at the university. I found students having my same difficulties of when I was young to learn this topic. But 25 years have passed, and now students don't even study anymore on books. So how is nowadays? Well, I made the same question to ChatGPT, and I asked ChatGPT, how do you classify glomerulonephritis? And ChatGPT gave me exactly the same answer that I had studied 25 years ago before my exam. So told me that glomerulonephritis can be classified in primary or secondary. And this is a distinction that could have a meaning when many things in medicine were considered primary or idiopathic. So we really didn't know why that organ was affected by those type of diseases. And I can make you many examples of why this nowadays doesn't fit anymore. I could mention one, membranous glomerulonephritis. This is a disease where you can have it only as a disease of the kidney, or you can have it in the context of a systemic autoimmune disorder, like, for example, lupus. But it's still the same identical immunopathologic process. What matters is the antigen and where this is localized, but the target for the treatment is the same kind of immunologic response. And so these patients are treated in the same manner. And another possible classification is the one based on the morphology, so on how this disease appears under the microscope. But now we know very well that even if this is very important to know, because it helps us to better understand which is the pathological process that is going on, this doesn't really fit frequently with the etiology of the disorder, and so with the way we should treat the patient. And I could make many examples of this. Maybe focal segmental glomerulosclerosis is the best one of all. A pattern of injury that associated with podocyte injury that can be caused by completely different etiologies, genetic, autoimmune, or, for example, toxic, infectious, and I could continue. And then the third option is to use an immunological classification that categorizes the glomerulonephritis based more on the immunologic process, but still doesn't always use the criterion of the immunopathogenesis. So sometimes mentions the etiological factor, sometimes the name of the discovery, the type of antigen, and also this is not very helpful then to know how to decide to treat the patient. Here I could make also another example that is taken from a disease that has recently been reclassified, so in the most recent years. And this is C3 glomerulopathy. In this manner, we even bypass the pattern of injury that we observed in the glomerulus to rather focus on the alternative pathway of the complement activation that is observed in these patients. But still, in these patients, you may have completely different responses to the same treatments. And these are three different cases that we had recently in our unit, for example. First case, all with a similar, somehow, clinical history with hypocomplementemia. And the first one had a nephrotic proteinuria, a normal kidney function, a very active sediment, was positive to C3NF, and responded quite well to mycophenolate treatment, which is usually the standard of care in these patients. But then we had another case that had had a previous flare following a vaccination. And in the moment that we saw the patient, this flare had somehow ended. The kidney function was normal, had a nephrotic proteinuria, the sediment was inactive, there were no C3NF, no anti-factor H. The patient was put under supportive treatment with RAS blocker. Meanwhile, a genetic cause of the disease was identified, and over the time underwent complete remission, simply titrating the doses of the RAS blockers. And the third case was a case with still a nephrotic proteinuria, but an extremely active sediment when arrived at the visit. Together with the hypocomplementemia, the patients had a rapidly progressive course of the disease with a worsening of creatinine in few weeks, no response to steroid, but responded in a dramatic manner to eculizumab with a complete recovery of the kidney function from 2 of creatinine to 0.7 in few days, and then had also a complete remission gradually in terms of sediment and proteinuria. So these are three patients that are supposed to have the same disease based on the classification, but that have completely different clinical history. So the main reason, I think, why we need to rethink a bit how we define and classify glomerulonephritis is all the knowledge that has been accumulated in the recent years, because now we know a lot more than when we were using this glomerulonephritis classification that I had to study at the medical university. And so we tried to focus a new classification mostly on the immunopathogenesis, thinking that this is what drives the choice of immunotherapy. And first, we published this first attempt in January in Nature Reviews Immunology, focused a lot on the immunopathogenesis. And after 2 months, a further update, a bit more practical in NDT, that also included, in addition to the classification by immunopathogenesis, an add-on that is the definition of the immunological activity and chronicity of the glomerulonephritis, because we think that this is also another major determinant for the choice of the treatment. So, based on the immunopathogenesis, we defined 5 different classes of glomerulonephritis: infection-related glomerulonephritis, autoimmune, alloimmune, autoinflammatory, and monoclonal gammopathy related. Why this? Because infection-related are due to innative and adaptive immune response with or without molecular mimicry, but to an infectious agent, and the immunopathology driven by this process. Then there are autoimmune glomerulonephritis, where there is still activation of the adaptive immune system with a response to autoantigens usually. And then there are alloimmune GN, where the adaptive immune response is against the donor antigen, and it's typical of kidney transplant. In autoinflammatory GN is mostly characterized by inborn errors of innate immunity, and the monoclonal gammopathy related GN to the presence of a paraprotein produced by a B cell clone or a plasma cell clone that drives the immunopathology in the kidney. Let's see them one by one and make a summary. So infection-related glomerulonephritis can, if we try to simplify the concept, focusing a lot on the immunopathogenesis, can be divided into 3 big subtypes. One is post-streptococcal glomerulonephritis, and this is a very specific type that is characterized by this very specific activity of the group A beta hemolytic streptococcus and its antigens to activate directly or by inducing anti-factor B antibodies the alternative pathway of the complement. Then the second type that is usually related to other infection, mostly bacteria and particularly staphylococci, but also virus or parasites, that drive an immune complex deposition in the glomerulus. And this usually happens in 3 specific conditions. One is when there is a primary or secondary immunodeficiency in the patient, because the formation of immune complexes requires, first of all, that the antigen, so the pathogen, is not cleared efficiently. And this happens during immunodeficiencies. So this an immunodeficiency can cause the persistence of the antigen, of the pathogen, and the persistence of the pathogen drives the generation of immune complexes. For the same reason, also the colonization of implanted device can be associated with immune complex glomerulonephritis. Think to a catheter, for example. And this happens because also in this case, the immune system has more problems to try to clear the pathogen, because these devices are more difficult to reach for the adaptive immune response. And the third condition is when there are pathogens that have particular escape strategies for the immune system. One beautiful example is the schistosoma that covers itself with antigens of the host, and in this manner can escape the response of the immune system. That's why it gives chronic infection. And these are all conditions that can be associated with the development of immune complex that then precipitate or deposit in the glomerular filtration barrier and drive immune complex glomerulonephritis. Then the third type is driven by usually cytotoxic effect of pathogen that can directly infect podocytes and drive locally the production of type 1 interferons that have a toxic activity for the podocyte and promote parietal epithelial cell growth, and they are remaining undifferentiated. And this happens particularly with certain viruses like HIV, EBV, herbovirus, parvovirus, B19, or SARS-CoV-2, and happens particularly in subjects that have a genetic susceptibility that are particularly APOL1 genotype carriers. And in rare cases, persistent infection can also cause AA amyloidosis. Now, we all know that this different type of glomerulonephritis can all be associated with completely different pattern of injury, so lesions at the light microscopy biopsy, and the same somehow is true. There is an heterogeneous pattern also in the immunofluorescence, and we can have also sign biomarker of an ongoing autoimmune process, because sometimes this disease, this glomerulonephritis, can mimic an autoimmune disease. For example, patients can be transiently positive to antinuclear antibodies or cryoglobulin or other autoimmunity markers, but this is usually a transient positivity that disappears once the pathogen is cleared. And what is very important in focusing in this infection, in this type of glomerulonephritis on the infection, is the fact that the primary target of treatment in these cases is the infection itself. So there are many reports that describe a spontaneous healing of the glomerulonephritis once host defense is able to eliminate the pathogen. And without controlling the infection, in these patients, the use of immunosuppressant is questionable and may even be counterproductive for their capacity to impair the host defense against the infectious agents. There was, for example, a recent study published on a randomized controlled trial on the use of steroids in these patients in infection-related glomerulonephritis that reported similar rate of renal recovery at 6 months in treated and untreated patients, but an extremely high difference in the term of adverse events, obviously higher in the patients treated with steroids. Then let's pass to autoimmune GN. Here we can have a list of many different subtypes, and probably under this category are listed the most frequent glomerulonephritis that we see, like membranous, like all the nephropathies associated with autoimmune disease, IgA nephropathy, autoimmune podocytopathies, and cryoglobulin, some forms of C3 glomerulopathy, and anti-GBM glomerulonephritis. But the pathogenic mechanism at the base of all these different glomerular disorder is similar. What changes mostly is the antigen that drives the adaptive response. So, and then the pathological mechanism are driven by the deposition of this complex between the antigen and the autoantibody in the glomerulus, and the activation of damage with then different modalities depending from which is the cell target. And of course, here we can have different biopsy lesion pattern, but it's not the lesion pattern the target of the treatment in these patients. It's rather this nephrotoxic agent that is produced by a cell of the immune system, usually a B cell or a plasma cell. And we now have many immunosuppressive agents that we can use in these patients, but they all target the immune cell. So at the end, they work outside the kidney. They work in the lymph node, in the spleen, in the bone marrow. So where the clone is present and is active to produce the autoantibody. And that's why, in my view, this glomerulonephritis should somehow be being considered as a whole group. Okay, but then there are two other points that still within the same group of disorder grouped by immunopathogenesis can still drive completely different response. to the treatment that we choose. And these are the immunological activity and or the degree of chronicity of the disease. Let's focus on the immunological activity. A patient can have a quiescent disease, so not active at all, or can have a low activity, a moderate activity, a high activity, and this may need to increase the intensity of the immunosuppressive treatment. Let's make some example of signs of disease activity. I think we should always focus, give a lot of importance, even more probably than what is commonly done, to the sediment, because frequently diseases with very active glomerulonephritis have not only a large amount of blood, but also many leukocytes. And this is of help to identify patients that are very active. This is particularly true, for example, in certain forms of acute C3 glomerulopathies or of post-infectious glomerulonephritis, or in less. Then there are blood biomarkers that we can use, autoantibodies, the level of autoantibody, sign of systemic disease activity when there is an autoimmune disease in the back. Then there is the biopsy, of course, and there are biopsy sign of activity. This is commonly used in lupus, for example, but also common signs of a high activity are the crescent. We can use the infiltrate, the presence of TMA, and so on. And then I think a particular caveat should be posed to proteinuria that is always the consequence of podocyte damage, and this obviously can occur in an acute manner in a very active disease, but can also happen in a patient that has a completely quiescent disease in terms of activity and instead has a severe chronic and progressive damage that is maintained through hyperfiltration. And in this case, this patient won't respond well, obviously, to the immunosuppressive treatment. Well, I think here we can also do another example that we all know very well. It's IgA nephropathy. I think the majority of the patients that we see are patients that really don't have an active disease. They are mostly chronic patients, and that's why we know that in these patients, the supportive therapy is extremely important. And more important than the use of steroids that is associated with a limited beneficial effect in comparison to the risk of side effects. But then we know also that there are some, not common, but some cases of patients with IgA nephropathy that can also have an extremely active disease. Like, for example, these patients that had even crescents in the biopsy, an extremely active sediment, a rapid worsening of kidney function, and was successfully treated with MMF, for example. So in this term, with the kind of classification that we propose, these two different types of IgA nephropathy should be defined as autoimmune GN IgA nephropathy subtype, but with A0 of activity, the first one, and with an A3 of activity, the second one. And this would justify the choice of completely different treatments. I can make another example somehow coming to this recently defined subtypes of autoimmune podocytopathies described by Astrid Vines that observed antinephrin antibodies in the biopsy of patients with minimal change disease. We started to use routinely the detection of antinephrin antibodies in the biopsy of our patients. When we have nephrotic syndrome, I can say that we find them not only in minimal change disease patients, but also in FSGS. But, and here you can see that the deposits are labeled in green, and the nephrin is, the nephrin is labeled in green, and the deposits are labeled in red. And here you can see that the two labeling somehow co-localize, while instead in membranous glomerulonephritis, they are localized in two completely different ways of the glomerulus. Well, these are both autoimmune glomerulonephritis, but the first one should be defined subtype antinephrin positive, and these patients had a nephrotic proteinuria that then went in complete remission to MMF and did an A2 activity. And the other patient is still the one with membranous, an autoimmune GN subtype with PLA2R type, because had the PLA2R autoantibody positivity, and was treated successfully with rituximab with a similar degree of activity, still A2. Then let's come to the alloimmune glomerulonephritis. This is the transplant-related glomerulopathy that is linked to alloantibodies binding HLA or non-HLA antigens in the allograft. And we know that many diverse lesions can be associated with transplant glomerulopathy, so many different patterns of injury, but the disease, but the treatment is always the same. And this decided based on the severity of the glomerulopathy. And here we come again on the concept of immunological activity. If we compare these three situations, so the presence of a disease like, for example, membranous nephropathy or ANCA, where you have autoantibodies directed against a single antigen, and this is a disease that usually can be solved also with a single immunosuppressive agent focused on the B cell response, but and that easily targets the clone. But then there are diseases like systemic lupus erythematosus where the problem involves not only many clones and many antigen, but many effector pathway of the immune system. And so here usually a combination therapy is needed. And this is even more true in the alloimmune glomerulonephritis that are related to kidney transplantation, where you still need a powerful combination therapy, exactly because, once again, here the problem is not the tolerance, the loss of the tolerance like in lupus, but is the lack of the tolerance to the transplanted kidney. So the concept is the same. And that's why you need combination therapy to address these patients. Now we come to another group that is the one of autoinflammatory GN. Here we define subtypes that are related to the type of inborn error that there is at the base of the disease. So we can have complementopathies, interferonopathies, or AA amyloid deposits in periodic fever syndromes, for example. And frequently these are genetic forms, and obviously the pathological mechanism is the overactivation of the pathway. For example, in the familial Mediterranean fever, the IL-1 beta production, or the complement alternative pathway overactivation in the patient with C3 glomerulonephritis. And also the kidney biopsy lesion pattern obviously can be in this group of diseases very different. But I think here we can make a couple examples that are different to understand the reason. This is, for example, the group of type 1 interferon-related kidney disorder. They can present with whatever type of glomerular lesion. And the reason for this is that in the different type of glomerular lesion, there is an association with production of type 1 interferon by different type of cells and response to type 1 interferon by different type of cells. So if the target of the type 1 interferon, for example, is preferentially the parietal epithelial cell, you mostly get the crescent or the collapsing lesions. While, for example, if this is in vessel, you get more TMA kind of pictures. And in membranoproliferative pictures, it's a lot about the production by the podocyte. So somehow this explains why this is a whole group of disorders, all driven by problem with type 1 interferon, but with completely different lesions at the biopsy. And now there start to be also some drug that can be used to treat with disorder, although currently what is approved is only anifrolumab. And then there is another group of subtype of this inflammatory GN, autoinflammatory GN, and these are the complementopathies. I think here what is very interesting to mention is that is coming out the evidence that these patients, because this has been controversial for some time, can be treated with complement inhibitors. Now there are many trials going on in these patients, but already with eculizumab, that was the first drug that was available to inhibit the complement, and that is already available since many years now, were reported completely different responses of this type of patients. And a recent paper clarified a bit the reason why, and associated the strong response to eculizumab to C3 glomerulopathy patients that have very active forms of the disease, frequently rapidly progressive glomerulonephritis, because obviously these are patients that have an active flare where the complement is the main driver of the damage, while the response of the patients with chronic forms is considerably less relevant or frequently known, as reported also by many studies. And the reason is probably that these patients have a chronic form frequently, where then the activation of the complement is minimal or absent. And from this, one can understand the reason why this respond worst to the eculizumab treatment. Then if this is something that can be in part bypassed by the new complement inhibitors, we will see soon with the result of the several phase 3 clinical trials that are going on now, but also chronicity may be an important contributor to a not good response to complement inhibitors of this type of patients. And then finally, there is monoclonal gammopathy related glomerulonephritis. This is a group of disease that are characterized by the presence of a paraprotein produced by a B cell or a plasma cell. So the subtype are those associated with myeloma, leukemia, lymphoma, whatever disorder associated with clonal lymphocyte expansion. And then there can be AL amyloidosis, monotypic fibrillary glomerulonephritis, crystalloglobulin glomerulonephritis. Here, the mechanism of damage is always the same. What you can see in these patients is sometimes you can detect the clonal immunoglobulin already deposited in the glomerulus. Sometimes this is not possible, and the clone producing the immunoglobulin should be searched somewhere else. For example, sometimes you can find it in the bone marrow or in the blood. But this is very important to determine, because it's the most important thing for the treatment of the patient to know. And this was first reported in a paper in Blood in 2017, where it was first shown that chemotherapy in these patients, so treatment targeting of the clone that produces the paraprotein, is the more effective way of treatment, even in comparison, for example, to immunosuppressants. And there was a more recent study recently that directly compared clone-targeted therapy with immunosuppressive therapy and conservative treatment, and strengthened these results. So in these patients, the treatment should be focused on the clone, and so on the disease, frequently at the base, or anyway when it goes to the clone. And this is the good treatment for the patient. Then what remains to be analyzed is the contribution of the chronicity lesion in determination of the choice of treatment. We have already spoken a bit about it. It's important to understand if a patient is only active, or, for example, has a mild fibrosis, CKD, or an advanced stage or significant fibrosis on the kidney biopsy, advanced stages of kidney failure, tubular atrophy, for example. And we can take exactly the same parameters. I think, again, as a first entry criterion, already the sediment is frequently of help, because in a disease that usually causes an active sediment, finding only proteinuria can be a sign, an initial sign to evaluate of something that is probably mostly chronic and not anymore so active. There can be blood biomarkers that can help. The same we mentioned before. There can be the biopsy, obviously, is of great help. The presence of focal segmental glomerulosclerosis, the tubular atrophy, the interstitial fibrosis. And again, be careful how you evaluate proteinuria, because an isolated proteinuria or with very mild signs of activity of the sediment can be simply the sign of a chronic disease that basically has become a podocytopathy, even if in its initial phase was a glomerulonephritis. And that's very important now because we have many new drugs. We don't have only RAS blockers. There are other drugs that are coming up. We have now SGLT2 inhibitors. There is sparsentan. Likely we will soon have even finerenone. So many drugs that can help the patients to reduce the chronic weight of the disease. And we should never forget that this goes together, I think, a full control of all the risk factors for CKD progression. I frequently say to my students that patients with CKD should always be treated like heart patients, like patients with cardiovascular risk. We would need the Framingham score exactly like the cardiologist. We should always evaluate also if our patients, for example, have obesity, have diabetes, have low nephron mass, have some genetic weaknesses, because this can significantly contribute to a faster progression in a patient with a glomerulonephritis. So in conclusion, to return to the case from where we had started, now we can understand why these patients needed different treatments, and obviously the name helps, I think, can help even more to define this from the beginning. The first patient was an active patient. That's why it responded so well to MMF, and that's why we can define it autoimmune glomerulonephritis of the C3 subtype, but with activity 2 and no chronicity. The second patient was a patient with a genetic complementopathy, so was an autoinflammatory glomerulonephritis of the C3 subtype still, but had anymore no sign of activity and had rather a chronic damage driven by the disease. And the third type was an hyperactive patient with a rapidly progressive glomerulonephritis and in a complementopathy. That's why it can be defined as an autoinflammatory glomerulonephritis of the subtype C3, but with an activity 3, and this explains well why it responded so well to eculizumab. So to summarize the content of my talk, I think that all this pattern of injury that we are frequently used to mention as if they would have been disease, they are no disease. Membranoproliferative GN, C3GN, DDD, and minimal change, FSGS. They should be used, obviously, on the biopsy report, it's obvious, but never be used as diagnosis. Grouping by pathogenesis accommodates better the choice for the nephrologist of the increasing number of immunotherapies available. Activity can, definition of activity of the disease can help to better focus on which is the level of immunotherapy that is needed in that patient. And I would like also to mention the importance of having a new way of classifying these diseases, particularly for clinical trial, because I think that this is a major problem of our discipline. Still, clinical trials are done grouping by lesions, C3 glomerulopathy, FSGS, and obviously we know that inside there are completely different patients. And so we run the risk that a drug that is good for a subset of these patients is discarded simply because won't be significant on the whole group if this was classified by the lesion. And there are patients with completely different causes that obviously will not benefit from that treatment. For activity, we need to use serum and urine biomarkers. Frequently, these can help understanding even without the need to repeating the biopsy. I think we should reconsider more urinary sediments, and also the response to the treatment is an important criterion, keeping in mind drug non-adherence. And then it's very important to establish also the degree of chronicity, because this triggers CKD by itself, and it's important also to choose the intensity of this type of treatment in patients. So to summarize again, you can see these 5 types of glomerulonephritis: infection-related GN, autoimmune GN, alloimmune GN, autoinflammatory GN, monoclonal GN, that can be defined based on the workup of the patients that we obviously already do in our clinic, but this can help to better focus on the right treatment choice for the patient, keeping in mind also activity and chronicity. So I would like to thank in particular the other people that together with me worked to this classification, and these are Hans-Joachim Andertz in Munich, Richard Kitching in Melbourne, and Nelson Lung in Rochester. And I would like also to thank my co-worker, and particularly for this talk, Fiammetta Ravaglia, that is our nephropathologist, and Maria Lucia Angelotti and Valentina Ragnanti, that take care of the diagnosis of the patients with immunofluorescence and high-resolution confocal microscopy. And I thank you for your attention.
Thank you very much, Paola, for this very innovative and interesting talk. I would like to ask the audience to submit their questions now via the chat tool. So I think you can see it, and it's self-explanatory. While we are waiting for some questions, maybe I can start with one question. I agree, we do need a better classification of the glomerulopathies. With me, it was the same thing. I was confused by this chaos of descriptive entities. So it probably comes from the fact that people were able to look through the microscope and then describe the disease, and we knew nothing about the mechanism. And now that the mechanisms emerge, we can understand the disease much better. And now comes the question, do you think we are already there? Can we already reclassify the GNs with the knowledge we have? Or how do we go about uncertainties? You know, are you 10,000 years too early with your proposal, or is it the right time?
Yeah, you are right. It's a good point. I think obviously this knowledge will progress further and further. There are still many things we have to learn, and we will need probably to update this classification many more times. But I think that currently it still works too much that we keep using these, as you said, these entities that were classified at the moment that we were looking at these diseases under the microscope, and this at the end drives the behavior of many clinicians. And I think it's in the experience of everyone that still happens to see patients that have FSGS and are treated with steroids or immunosuppressant, even when they don't have an autoimmune cause, immunologic cause of this disease, or I could do many other examples, because we are set by the attitude to use these lesion patterns as if they would be diseases, to think in that direction. And sometimes this become even a legal problem. Huh? I mean, they still do trial with that, because at the end, even if you are not convinced that the patient has a disease that is related to that, but you don't get any other response, you don't deny that treatment, because it's still reported to be as the most important also in many guidelines. So and I think the problem is even bigger is clinical trials, because we really run the risk to discard drugs that can be useful for some of these patients, simply because they are grouped by lesion when they do the clinical trials. I think this happens with FSGS. Recently also, for example, the use of I think the use of dapagliflozin and the use of sparsentan that still gave good results in terms of proteinuria and significance. I mean, probably their effect on GFR is still not optimal, exactly because patients with FSGS are not all the same. And some will probably benefit for this chronic, for CKD treatment much better than others that have more active form and in autoimmune, with autoimmune etiology in that moment. Or C3 is the same story. Eculizumab was not used, I mean, there are many papers that say don't use eculizumab in C3 glomerulopathy, but it depends which type of patients you have. Very active C3 glomerulopathy patients respond extremely well to eculizumab. So, but if you have a chronic patient that has mostly a chronic damage, of course won't respond to eculizumab. So I think that this won't certainly be a new classification that has to stay there for a lot of time, but certainly accommodate, because we will change it soon with the new progress, but certainly accommodates our daily practice, I think, better than what we were doing before.
Mm-hmm. Yes, I have not received any questions from the audience. I hope that this is not a technical error. If yes, maybe the technical support can verify this. I agree, Paola.
But there are a few questions that just came in.
No, I don't
You
see
need to
them.
go to the question box.
I'm in the chat box. Oh,
not in the chat box.
Yeah. Okay.
You need to go
I see
to the other one. Okay.
Yeah. Mm-hmm. So first question, why you consider that it is more important the urinary biomarkers to repeat the renal biopsy, for example, in case of the treatment, no response in some patients. So why do you consider the urinary biomarkers to be repeated to repeat the biopsy in the treatment if the patient doesn't respond?
Well, okay, no, I mean, obviously, this is clinical experience. I mean, if you carefully look at your patient, in some types of glomerular disorder, the sediment can tell you a lot. Very active patients frequently have very active sediments. For me, it's common working with young patients and with kids in particular. Of course, this may be different with the patients with advanced age, where the chronic part of the damage is more or less always there. But in young patients, patients that have very active forms of the disease usually have a very active sediment, including even leukocytes. And sometimes in large amounts, particularly patients with infection-driven glomerulonephritis, C3 active glomerulonephritis, immune complex-driven very active glomerulonephritis. I don't say that this is more important than doing the biopsy. I don't want to be taken wrong. Of course, rebiopsy can be important, particularly think to lupus patients. But I think that we should not forget that the sediment is easy, is the first entry level, and can already give you important information in a patient that has a very active, a very acute form of glomerulonephritis. While I think that in chronic patients, when you have only proteinuria, you should always carefully consider which is the chronic component of proteinuria in that patient. Because patients that don't have sediment and have chronic proteinuria, or they have a podocytopathy, very selective, or they have a CKD with a strong component of hyperfiltration in the damage.
Yeah, we have another 4 questions, so we have to hurry up a little bit. The next question is, what is your genetic approach in subgrouping different glomerulopathies? Which genetic tests do you order regularly and in which type of GN?
Yeah. Well, this we recently published. It's in the April issue of JSON, and it's an algorithm of diagnostic that we have set up over the years. What we do is we do genetic to patients that have certain specific characteristics. For the group, I mean, for the glomerular diseases, we do genetic to patients that are resistant to treatment, so usually after first course of steroids, or that have have a familiarity of the disease, or have extrarenal signs of whatever kind, so that you can think to a syndromic form of the disease. When you have one of these 3 things, then we do exome sequencing, and in this manner, in glomerular disorder, we arrive at a very high rate of genetic diagnosis. So I think it's a specific subset of patients, and are mostly those that are resistant to the first course of treatment. This mostly for podocytopathies, I have to say. For the complement, yes, we do the extended genetic diagnosis too, but it's much more tricky. Only 15–20% of these patients really have a genetic cause. In most of the other, you will find the polymorphism frequently, or more than one polymorphism. Or sometimes what we've, so it's multifactorial disease. And then sometimes what we find, I have to say more and more often, are immunodeficiency, primary immunodeficiency.
And in pediatric patients, genetic causes are much more common than in adults.
Yeah, but I have to say, when you use as entry criteria the resistance to the immunosuppressive treatment, the familiarity, obviously, and the presence of extrarenal sign, then the frequency in this subgroup of patients tend to be similar.
Okay, thank you. The third question is, if one cannot find the clone cell, the one clone cell that causes disease, would it be just enough to treat the B cells in general, where we have monoclonal antibodies against?
This is a good point. Yeah, of course. If you cannot find the clone, and so you are not sure that this is a clonal disease, if I correctly understood the point. Anyway, targeting the B cell is never wrong. But the best thing to do is to search the clone when you have the suspect that this is there, for example, because you have a GUS, because you have a patient with a leukemia or a lymphoma or something like that. And because the clone targeted therapy, taking into account, now there is a lot of evidence, is more effective. Well, with this, you can ask help to the hematologists. They do it to search the clones. That's their job. I think we should also get more used to have this kind of collaboration when it happens to have a patient like that, because they can do it. Okay, thank you. The next question is, how can we classify non-genetic steroid-resistant nephrotic syndrome in children? Yeah, okay. This is I had a slide on that, but then I decided not to show it because I want to focus on the topic. But I think I have it. Wait a second, somewhere here. Okay, so this is a slide that I use sometimes for my students, and it's what we spoke about today is of glomerulonephritis. So these are these immune-mediated responses, mediated glomerular diseases. But I think that then there is another large group of disorder that are the podocytopathies. There is some some overlap of these two big groups of diseases, and are the autoimmune podocytopathies that I mentioned today. Obviously, the genetic podocytopathies are all included in the podocytopathies group, including forms of genetic podocytopathies that are, for example, secondary to collagen, because these are still all mechanisms of podocyte loss that are driven secondarily by the genetic mutation. So that's how I view the story.
Mm-hmm. Thank you. The next question is a little longer by David Navarro. I agree, manual urinary sediment is a great tool to evaluate GN activity. However, in my experience, having a proficient and rapid manual urinary sediment evaluation is rather rare in most nephrology departments. This problem is further emphasized in multi-center RCTs, randomized clinical trials, where urine evaluation is frequently centralized, and hence urine is not evaluated in a timely fashion. What is your opinion on this?
I fully agree. That's why I say that we should recover a bit the urinary sediment, because in many places it's not really analyzed and can give you a lot of information. A very active sediment is a way to quickly and non-invasively already have an idea of what kind of patients you have in your hands. And it's getting lost. It's getting lost in clinical trials. It's getting lost in many clinical nephrology units.
Yeah, thanks. And the final question is by Yasmin Yarkin. He says, thank you very, very, very much. And I would also like to say thank you very much for this really inspiring talk.
Thank you, Mark.
We need these novel initiatives.
Thank you.
So
thank you very much.
To you all. And this concludes this webinar.
Thank you. Bye.
Bye-bye.